Welcome to our cutting-edge online point-of-care ultrasound fellowship program. We are excited to invite you to this pioneering fellowship designed to empower healthcare professionals with advanced skills in acute care ultrasound. As a participant, you join a diverse global community committed to transforming patient care through innovative ultrasound practices in critical and emergency settings. Our comprehensive fellowship is meticulously structured into 2 immersive modules, each spanning 24 weeks. Whether you're just beginning your ultrasound journey or you're a senior clinician refining your expertise, this program is tailored for you. Our curriculum bridges the gap between theory and practice, providing an evidence-based, clinically relevant approach to ultrasound education. You'll explore critical applications, including shock volume assessment, cardiac function, and sonal anatomy, lung normality and abnormality pathology, several acute care procedural guidance, several real-life practical case scenarios, and much more. We understand the demands of your profession, which is why our fellowship offers unmatched flexibility. All interactive sessions are recorded and available on a user-friendly learning platform, allowing you to revisit key insights anytime, anywhere. Through expert-led lectures, real-world case discussions, and journal clubs, you'll gain a profound understanding of ultrasound applications, backed by the latest evidence. Our esteemed faculty consists of renowned experts dedicated to guiding and mentoring you throughout your journey. With their support, you'll enhance your skills and stay at the forefront of ultrasound innovation. By the end of this fellowship, you won't just master ultrasound techniques, you'll become part of a global network of like-minded professionals, fostering collaborations, knowledge exchange, and continuous learning in acute care ultrasound.
Thank you very much for this introduction video. Thank you, Habiba, and the IT support for tonight. And it's my great pleasure to welcome you all in this last live webinar that we're going to have as part of our program, the Advanced Critical Care Point of Care Ultrasound in Critical Care Medicine. And as I said, this is the last live webinar because we are in the week number 20. And as we used to do every 4 weeks, the 5th is for live webinar. We are very glad tonight to have Dr. Professor Michel Slama, Dr. Walid El-Habashi, and Dr. Mustafa Isam, myself, to cover the 4 previous transesophageal echo in ICU. And we are calling this webinar as let's sum up the previous 4 weeks in the transesophageal echo in critically ill patients. Something that we are very unique to teach, and something that the evidence is supporting that it's becoming more and more part of the point of care ultrasound, mandatory part of the point of care ultrasound at bedside. As we heard from the expert of this batch of transesophageal echo in different weeks, the transesophageal echo is found to be superior to transthoracic echo and much easier to get views in critically ill patients and much easier to learn more than the transthoracic echo. As we are aware that for the every live webinar, the live webinar idea came just for the faculty to meet the fellows and the fellows to ask their own questions if they have anything to clarify about the previous weeks. This is very, very important for all of us. And it's a chance for everyone, volunteers, for the fellows, to bring their cases if they have any, or we bring them our cases for discussions. So we have tonight again Dr. Professor Michel Slama, Dr. Walid Al-Habashi, Dr. Mustafa Isam, and myself to answer your questions. Where to put your questions? You can post the questions in the Q&A, and I will, with Dr. Walid, handle these questions and trying to answer them with our colleagues. Just to remind everyone in the fellowship that the next step is the neurocritical care section of the online fellowship program, week number 22, which is going to follow this week, start on 26th of August, will be covering the optic nerve sheath diameter to predict the intracranial pressure, will be followed by, and this will be presented by me, and the week number 22 will be all about the transcranial Doppler, and this will be by Professor Kaira Roba. And then we're going to have a week to review everything before the exam, the exit exam. So the exit exam will be on 16th of September and will end by 23rd of September. The graduation ceremony will be on 26th of September, this 2026. And as we did in the module 1, the exam will be composed of 50 multiple choice questions with best answers. You have to pass the exam with 60% pass mark, and you have 90 minutes to finish these 50 questions, and you have a week to choose one day, 24/7. You choose any date on this week and any time on this days, but just once you sit in front of the computer, you have 90 minutes to finish, and you have only one chance to finish the exam and pass. Otherwise, you're going to have another chance, and that's it. All has to be done through the week of 16th September till 23rd of September. The ceremony is a very nice opportunity for everyone to celebrate the great work they have done, the full year of hard work, both the faculties and the fellows or the candidates. So please mark your agenda for 26th of September to be online with the ceremony with WICCM graduation of different fellowships, particularly the fellowship of point of care ultrasound. What we're going to do now, Dr. Walid Al-Habashi kindly and Dr. Mustafa Isam, if you look at the Q&A section and see if we have any questions to be directed to any of us. Otherwise, I have now a sum up loops and views of transesophageal echo, and I will present them and ask questions, and kindly requesting Dr. Professor Michel Slama and Mustafa and Walid to comment and stop me at any time to comment on technical, practical tips for the fellows to know. As we said, the previous 4 weeks of transesophageal echo started with week number 16, and this was the basic views, how to get them, and how to recognize structures on the transesophageal echo. Week number 17 was all about stroke assessment using an intracardiac masses using the transesophageal echo, and this was by Professor Michel Slama. Week 16 by Dr. Mustafa Isam and myself. And week number 18 was all about hemodynamics using the transesophageal echo, and was by myself. And we ended up by Dr. Walid Al-Habashi, assessment of valve with transesophageal echo. Walid will present also uh, following me. He will present two interesting cases using the transesophageal echo. So Professor Michel Slama and Dr. Mustafa Isam, feel free to stop me at any time for comment on the views. Is that okay?
Yes.
Yeah, okay. Any comment, Dr. Walid, or any question to ask or to receive from the candidate?
I can see in not yet.
Not yet, okay. So as Dr. Mustafa Isam was showing us how to get the views.
Sorry, Ashraf, there's one question came just now from Nabil Bastawisi. How to handle the TEE probe?
Okay, Dr. Mustafa Isam, if you wish to start.
Yes, okay. Good evening, everybody. How to handle GE probe. As I mentioned in the lecture, we have to know the anatomy of the TE probe. The TE probe, you have a shaft with 100 centimeters. At the end of this is the tip that can be anti-flexed, vertiflexed, flexed to the right or to the left. And we have house which is a steering house. In this house, we have two wheels and knobs. When we are handling the TE probe, we have to stand beside the patient. Patient is either sedated or anesthetized. Don't forget about the mouse bites. If the patient is intubated, cut the side of the mouse bite and introduce the ET tube in one of the sides. After that, lubricate the TE probe. Uh, you can have help from another body to make jaw thrusts or to lift the chin of the patient, and you have to introduce the probe as you are introducing orogastric tube perpendicular to the patient with little anti-flexion. Introduce the probe slowly. If any resistance, stop. The trauma from the TE probe is rare, as we mentioned, is all the complications from TE probe maneuver 2.5 or 2.6%, but it can be hazardous in some patients. If you have a resistance, just stop and make some jaw thrusts or anti-flex little bit the TE probe with the inner wheel, which is the larger wheel, or you can even use gyroscope to guide you to introduce the TE probe. This is how to use or manipulate the TE probe.
Great. If I ask, please, everyone, if you have question to Dr. Professor Michel Slama, because he has to leave us after 30 minutes maximum. So please write a question. Professor Slama was talking about the stroke assessment and intracardiac mass assessment. Can I ask you, Prof, a question? Because we still have a lot of resistance to use generally the transesophageal echo in ITU or ICU. People, they believe that this is something advanced, very advanced, and it's invasive. If you would recommend transesophageal versus transthoracic echo, if you have to choose between both, you have this and that, which one you prefer, Professor Michel Islam?
Thank you, Ashraf, for this very important question. Because as you know, we now consider that these two techniques are complementary. So it means that you can have some flows that you can record only by using a transthoracic echo, and you have very good images usually by using a TE. So it was demonstrated that when you do transthoracic echo and after TE examination in ICU patients, so you will discover up to 20 to 30% of new diagnosis. And in 20% or 30% of this case, you can even change the treatment only by with the TE images. And that's very, very important. And even surgery, you can have for example, severe mitral regurgitations that you haven't seen on transthoracic echo, a big vegetation or whatever that push you to do surgery in patients. So in up to 10 to 15% of cases, you will have to do this treatment only on T examination. So that's why, for my point of view, the recommendation in ICU patient under mechanical ventilation is almost always to use TE on a patient in which the transthoracic echo doesn't give you the good information, and if the transthoracic echo fails to help you for the hemodynamical evaluation or for any evaluation, and you know that TE is much better for left atrium, for left atrial appendage, for quantification, assessment of mitral regurgitation, mitral stenosis, aortic regurgitation. And so that's why it's very, very important to do TOE. And so that's why I don't want to oppose, the transthoracic and TE. So I think that it's really two different and complementary examination. And from my point of view, is less than semi-invasive technique, because if you look at all the papers published previously on the safety on TE in ICU, is not in cardiologic field, so you have almost no complication. So you know that it was described some perforation of the esophagus, but most of the time it was described in the cardiologic field in a small patient, not under mechanical ventilation. And if you do the TE as it was explained, with a good view of the esophagus, when you push the probe slowly and gently, and you never, strongly push the probe, so you will never have any complication by doing TE examination. And more, you know that in few teams in France, they start to teach to the residents first TE, because
Yes.
TE is very easy to do. Somebody like Antoine de Herbaron is learning, is teaching only TE first, and after that transthoracic echo. So it's a little bit caricatural, of course, but it's just to let know to everybody that TE is mandated when you are doing echo, or if you manage patients in ICU.
And the environment of ICU is very ideal for the transesophageal echo, where you have patients sedated,
Yeah.
relaxed, and they are easy to pass the scope down. Dr. Walid Al-Habashi, did you ever encounter any case that you introduce the probe in and you don't see the heart?
Almost never.
Almost never, yeah. So once the
So
probe,
it is sometimes difficult. Certain views are difficult to get, but I can't imagine to put a probe down in the esophagus and you don't see the heart.
yeah,
It's theoretically impossible.
yes. And what you see in the transesophageal echo is the upside down, the image of the transthoracic echo. As you see here in this slides, in this one, that the apical four and the mid-esophageal four, the ventricles are down in the transesophageal, where they are up in the transthoracic. Look at the long axis, parasternal long, and this is the mid-esophageal long axis when you see the mitral valve and aortic valve, left ventricle and left atrium. And as we can see here, you can, once you manipulate the angle, you can see different structure that they are difficult to be seen by the transthoracic echocardiography. In around 30% of patients in ICU, as per evidence, there is no available transthoracic views in our critically ill patients. Yet they have questions to be answered, seeing the heart with the ultrasound. So the only way to see the heart is through the transesophageal echo. And a good example of this is what we learned from Professor Michel Slama when we have to see the left atrial appendage, and when we learned from Dr. Walid Al-Habashi how to assess the valves. Walid, go ahead. You wanted to comment on something.
There are actually a couple of questions sitting there. The first question is from Fadil Al-Zair, if I pronounce his name right. For a patient found to have LA or LV thrombus on ultrasound post-stroke, how does the thrombus morphology, like mural thrombus, mobile thrombus, and its size, change your decision of anticoagulation timing, given the hemorrhagic transformation risk?
I can see that this is out of the context of this webinar, but it's a good question to be answered if you wish, Dr. Professor Michel Slama. But we just remind everyone that if you are talking about left ventricle thrombus, transthoracic echo is far better than transesophageal echo for the left ventricle thrombus. Go ahead, Prof. You want to answer this question, Professor?
Yes, about the thrombus in the apex of the left ventricle and into the left atrium, yeah?
Yeah.
Yes, again, because using TE is very hard to see the apex of the left ventricle. That's exactly what you say, both of you. That's why sometime in, for example, after myocardial infarction, you know that the thrombus could be discovered up to 20 to 30% of cases. For example, for apical myocardial infarction. So you know that in dilated cardiomyopathy, you may have sometime a thrombus at the apex of the left ventricle. And so by using TOE is very, very hard to see. Most of the time, you don't see really the apex of the left ventricle. In contrast, if you are looking for a mass or if you are looking for a thrombus into the left atrial appendage or into the left atrium, the best route would be the TE, of course, because with your probe you are just behind the left atrium and you have a beautiful view, as you can see here. I think that Ashraf has a beautiful image here showing you that the left atrium is really against the probe, just in front of the probe. And then that's why you may have a beautiful image. And if you have even a small thrombus into the left atrial appendage, so you will see this thrombus. And as Walid said, so it will change the management of the patient if you have a thrombus, because you may, for example, start anticoagulation or whatever. And it's very, very important to have this route to diagnose any thrombus or any mass inside the left atrium, like, for example, myxoma or other mass.
Yeah. So identification of the structure is very, very important to start with. So as Professor mentioned, this is left atrium, left ventricle, right atrium is here. Mitral valve should be the tricuspid here. If you pull the probe a little bit up from the mid-esophageal 4, you see the mid-esophageal 5. And here, once you manage to get the angle increased, you might see the Mercedes sign of the tricasp aortic valve here in the middle. Up to this, you see the left atrium. You can see the left atrium very clearly here. You can see smoked or spontaneous echogenic contrast in the left atrium. One of the signs that might be very helpful if you are dealing with a stroke patient looking for source of embolization. So identification of structures, Mercedes sign of the tricasp of the aortic valve. Above it, you see the left atrium. Here is the right atrium, tricuspid valve, RV. So details of the aortic valve, which cusp, and if you see any mass attached to, you might see the root of the aortic valve. Above, as we said, you see the left atrium and then the recess in the left atrium, which is the left atrial appendage. This is the pulmonary artery here, and this is the pulmonary valve. This is the RVOT. You can put the color, and sometimes you can see the thrombus. One of the very important views when you have the mid-esophageal and you increase the angle to around 90 or a little bit above 90, you open the superior vena cava opening into the right atrium, and the superior vena cava is very important to reflect the volume status. This is what we call it the bicaval view. Why bicaval? Because this is superior vena cava, and opposite to it, you see the inferior vena cava here, and this is the Eustachian valve, part of the bicaval, part of the inferior vena cava.
Can I comment, Dr. Ashraf?
Ashraf, there is actually, sorry to interrupt. Ashraf, there is actually a comment here or a question from Dr. Nabil again. How to use this bicaval view to assess for the fluid responsiveness or actually the fluid tolerance.
Good.
So just Ashraf and Walid, just to just a small comment on this view. This view is beautiful because you can see very well the superior vena cava and inferior vena cava. This view is very important, for example, for ECMO. When you insert the cannula, to be sure that the cannula is in the right position. That's perfect view. If you really want to follow to assess the fluid responsiveness of the patient, and if you want to follow the papers published by a few authors, particularly by Antoine Verbaron, then you have to a little bit pull out the probe. To see not the right atrium and the left atrium, but you should see close to the probe the right pulmonary artery, and then at that time you can have a better view, a better longitudinal view of the SVC, and at that time you can put the M mode line on the superior vena cava at 90 degrees, and having the possible respiratory changes of the superior vena cava. And you know that the first description of Antoine, demonstrate that if you have a respiratory change more than 36%, so you are almost sure that the patient is a fluid responder, and even the patient is hypovolemic. So it means that if you have a large respiratory changes of the superior vena cava using the M mode technique on the view that I described previously, so at that time you are sure that the patient will increase the cardiac output when you will give the fluid to the patient.
Good. So if you see on this bicaval, as Professor Salama said, you fire the M mode here, Dr. Nabil. You fire the M mode over the superior vena cava, and you see the variation, the maximum diameter and the minimum diameter, and you go with the collapsibility index. So the maximum minus the minimum divided by the maximum times 100. And the studies showed that if the collapsibility index of the superior vena cava is more than 36%, your patient is hypovolemic and fluid responsive. If you see the tricuspid valve, then you might see two tubes here. One here is the inferior vena cava. This is the inferior vena cava and the coronary sinus. Dr. Mustafa Isam, you want to comment
Yes.
here?
Yes, sure. This is modified by caval view. Just to increase the angle to 110 or 120. You will find at 7 to 8 o'clock that tricuspid valve. And I'll give you some for the embryology, يعني something كده for the embryology for the human being. Coronary sinus is what? Is the venous drainage of the heart. So God created it very close to the tricuspid valve. It's always adjacent to the tricuspid valve. So it can trickle low flow blood to the tricuspid valve. Don't forget my comment to identify between the inferior vena cava, which is above, and the coronary sinus below. So this is the tricuspid valve, and the tube above the tricuspid valve is the coronary sinus.
This one.
Above,
This
yes.
one. Yeah.
Yes. And the one above
And
is the
this is
uh,
the inferior vena cava.
inferior vena cava.
Yes.
Yes. Okay.
And
It
as
helps
we know,
us in structural in structural heart disease when we are in structural heart disease in cath lab when the operator is introducing his device مثلا ESD closure device. تمام.
yeah,
This is the Eustachian valve. تمام. What's above the Eustachian valve is sinus venosa, inferior sinus venosa. And
this is
what
too much
below?
advanced.
Okay. Yes. Okay.
I know you're doing a lot of
Okay.
things like this in cardiac surgery,
Okay.
in
Okay.
anesthesia of cardiac surgery. Thank you, Mustafa. But again, identification, superior vena cava, opening to the right atrium, tricuspid valve is here, the coronary sinus, as Dr. Essam said, inferior vena cava, this is the interatrial septum, and this is the left atrium. And you can do the bubble test as we're doing here. We're injecting into the internal jugular subclavian, and it goes to the superior vena cava into the right atrium. The bubbles, if it goes to the left atrium, and then you might have the patent foramen valve, or here again, this the superior vena cava, the pectinate muscle, right atrium, the septum is here, and this is the left atrium. You inject to diagnose right to left shunt or left to right shunt. Again, you can see the details. If you zoom on the septum, you can see if there is any connection between the left and the right. Very important to notice the ridge, the remnant between the superior vena cava and the recess in the right atrium, which is the right atrial appendage. And this is sometimes is missed as a thrombus, the same we see on the left side. And that's why it's called the Comedon ridge, because on the previous days or years, old days, they believed that this is a thrombus and they start patient on Comedon or warfarin. But it was the remnant, prominent, normal anatomical ridge there. Can be seen on the right side and can be seen on the left side. We'll come to this. And this is Dr. Nabil again, how we fire and what we see when we fire the M mode on the superior vena cava. You see the maximum diameter, the minimum diameter, the difference between divided by the minimum diameter. You have to link this to the inspiration time and expiration time, of course, as we mentioned this in the presentation of the hemodynamics. I want to go very quickly to this important part. I hope Professor Michel Islam is still there. How we diagnose that in young stroke patients or any stroke patient when you suspect that the heart is the source for the embolus. You might see smoke, a turbulence of the flow in the left atrium or the left atrial appendage. We call it spontaneous echocardiographic contrast, SEC, or it might be sludge, the same sludge that we see, the same as the sludge we might see in the gallbladder. We have this in the week of gallbladder, or you see a thrombus like a mass. So what's the smoke? If you see here, you see that the flow inside the left atrium, or here in the left atrium here, or left ventricle, or the inferior vena cava, that the flow is showing as if you are injecting a contrast. This is a spontaneous echocardiographic contrast. This is this is left atrial smoke. It's a very high risk for a thrombus formation. It's the pre-stage of the thrombus. You see here the sludge. It might be part of it is a sludge in the inferior vena cava, and it developed into this, something like this, a mass or a thrombus. So these are the different stages of thrombus formation.
Ashraf, sorry, just a small comment. With a new probe, particularly with a new TE probe, sometimes we may have this kind of smoke and it's normal. So you have really to take care because with a new probe, because the due to the amazing improvement of the quality of the probe, so sometimes you may see like this a small smoke even if you have a normal flow in some patients. So take care about that with the new, particularly the new TE probes.
Yeah, some people, they advise, if you suspect the contrast, is to increase the gain or play with the gain.
Yeah.
Okay. If you have comment, Walid or Isam, you go ahead and say it. Any questions, Dr. Walid, from the candidate?
Yes. So in a patient with dilated RV with septal flattening, like a D-shaped left ventricle, when would we give fluids and when not? So giving fluids may actually worsen the hemodynamics. What's your comment on that? So hemodynamic management in case of acute RV strain or RV syndrome, where there is interventricular dependence.
Yeah.
So
very good question.
Yeah. So as you know, we have done a big study with Philippe Vignon and Antoine Vieillard-Baron with a very nice figure comparing the size of the right ventricle and the fluid responsiveness. And when you have a dilation of the right ventricle, almost never you have a patient who is fluid responder. So for, at least for our point of view, for French team, so if you have dilation of the right ventricle, don't give fluid to the patient. Don't give fluid to the patient.
It's absolutely
So it's a little bit caricature, but I think it's a good message.
Yeah. Especially if you have septal flattening and shift. This is considered to be,
of course,
hazardous if you give fluid.
Of course, because if you give fluid to the patient, what happens? Most of the time, if you have a paradoxical septal motion during systole, so it means that you have a pulmonary hypertension. Then if you give a fluid to the patient, due to this obstruction into the pulmonary small capillary vessels, so of course, if you give a fluid to the patient, it will stay into the right ventricle and increase the size of the right ventricle, increasing the interdependence between the right and the left ventricle, decreasing the size of the left ventricle as a consequence, and then you will decrease the stroke volume and the cardiac output, and then the patient will crash. So that's why in almost 99% of cases, you don't have to give fluid to these kind of patients, particularly as Ashraf said, when you have a paradoxical septal motion at the end of the systole.
And this has to be particularly attention when you have patients with pulmonary embolism or RV infarction, because we inherited messages from the cardiologist that every RV infarction is fluid, they need fluid. And this is I'm sorry to say, not right, because you give fluid cautiously to RV, myocardial infarction, when they're dilated. If you have a follow-up of the cardiac output and you see with the mini bolus that the cardiac output increases. Otherwise, giving fluid to dilated RV might be hazardous. So this is one of the advantages of having echo examination. So transthoracic echo, you can see the left atrial appendage, though it's not common. You see it here in the apical 5. Here is the left atrial appendage. In the apical 2, this is the left atrial appendage. In the short axis, modified parasternal short, this is the left atrium here. You might see a thrombus in the appendage here, and this is the apical 4, but you might be not able at all to see the left atrial appendage, though it's the very common source of embolization or embolus formation if you're talking about the source of embolization in critical ill patients. We see the left atrial appendage in the transesophageal echo in 100% of patients. And here is the left atrial appendage. You have to adapt your eye to see it. You want to give any hint, Dr. Mustafa Isam here. This is the appendage. This is the ridge between the appendage and the pulmonary vein. And if you want to comment here, Dr. Mustafa Isam, for this view.
Yes. Just to make sure there is a flow in the left atrial appendage, we have to put our pulse width Doppler few millimeters from the base of the left atrial appendage to see the flow inside the left atrial appendage. Because sometimes we have smoke in the left atrial appendage and we don't know if there is a real thrombus or just smoke. Heavy smoke, consider it as a real thrombus, because heavy smoke, sure, there will be underlying some minute thrombi. But we are talking about questionable smoke. Yani, this is heavy smoke. I decrease the gain, I increase the frequency, but still there is a smoke. You have to put the, yes, this
and
is
where
what
you put the Doppler
few millimeters from the base of the left atrial appendage.
Say it
This is
again.
key. Yes, يعني about half centimeter from the base of the left atrial appendage, the opening of the left atrial appendage.
Yes.
If you have 0.5 or 0.6 flows, that means it's very far away to have a thrombus in the left atrial appendage. If you don't have a flow or a very blunted flow, it's very suspicious to have a thrombus in the left atrium.
So this is how we recognize the left atrial appendage thrombus. Number one, you see the contractility and emptying of the left atrial appendage. Look at this left atrial appendage here. It empty with systole and diastole. And you put the color on, as I showed in the previous one here. It doesn't take any color. And you can see the smoke that Dr. Mustafa Isam is talking about here. And you see how it doesn't empty when there is a systole, and the flow here, the Doppler, and you can see any Doppler velocity less than 20 centimeter per second is considered to be a suspicious or evidence of thrombus. You might see the thrombus itself. See here, this is the left atrium, and there is a mass here, and there is a mass near to the appendage, and mass inside the appendage. Multiple masses in the left atrium and left atrial appendage. So again, the signs of left atrial appendage thrombus, one of the great advantage of the transesophageal echo in critically ill patients who present with a stroke, and you want to know from where this stroke is coming, those with EF, those with mitral valve stenosis, you see the spontaneous contrast, you see the sludge or the thrombus itself, you might see the loss of contractility or emptying, and you might see the pulsed wave Doppler velocity very low. I will stop here to give time for the presentation of Dr. Walid Al-Habashi, and then Dr. Mustafa Isam has also some loops to show us. Thank you very much.
There is a question for Prof. Slama. patients with low tidal volume, means low tidal volume on mechanical ventilation, are dynamic indices still valid to use?
Thank you, Walid, for this very interesting question. As you know, almost all the indices involving the mechanical ventilation, so involves the heart-lung interactions. So it means that if you don't have a good or high changes of the pressure into the lung and into the chest, so at that time, of course, you will not have any interaction between the heart and the lung. So that's why most of the indices were described under mechanical ventilation with a tidal volume of at least 8 milliliters per kilograms. And then if you have a lower tidal volume, for example, 6 or even 5 if you have a patient with a severe ARDS, so at that time, of course, you will not have any interaction between the heart and the lung. So it means that, of course, you will have no change of the flows, no change of the superior vena cava. And it doesn't mean that the patient is not hypovolemic. It means only that you don't induce high pressure to assess the fluid responsiveness for assessing the patient hemodynamical status. So at that time, so you have different other ways to diagnose the fluid responsiveness, and the most useful, which was now clearly stated into all the recommendations, is to do a passive leg rising maneuver, because whatever is a mechanical ventilation, when you do a passive leg rising maneuver, so you will mobilize something like 300 milliliters of blood from the legs and from the abdomen into the heart, and then you will test the system. And then if the stroke volume and the cardiac output increase 1 minute after the maneuver, so at that time it means that the patient will be a fluid responders. And that's why today almost all the recommendation we say that you have to not to be too confident on the signs coming from the heart-lung interaction, particularly when you have a low tidal volume, and then you have to do something like a passive leg rising maneuver. Another way, if you can, is just to increase the tidal volume up to 8 milliliters per kilogram, and you will see if there is any interaction. Is a tidal volume challenge described by the team of Sheila Miatra with Jean-Louis Teboul. And so I think that if you do this maneuver, for example, for pulse pressure variation or aortic blood flow, so you will have a good assessment of the fluid responsiveness. But from my point of view, and for the point of view of all the recommendations today, is the best would be to do a passive leg rising maneuver.
Thank you very
Prof.
much.
It's just maybe important note here that Professor Michel Slama, Antoine Bavon, and Paul Mayo are conducting every year a very important transesophageal echo course over 5 days in Paris and in Ambry. Was the city of yours, Dr. Professor Slama? Can you unmute yourself?
Yeah. It's in Amiens. Thank you. That's very nice, Ashraf, to mention that. Yes, from the November 3rd, 30 to the December 4th, we are running a TE course, and it's very interesting course. Not because we are doing, of course, some simulation the first day, but after that, all the candidates will be able to do TOE on patients, on real patients in the ICU by themselves, and at the end of this 5 days they will have done at least a 10 TE examination. It's just because in France and in my unit we have a special insurance which cover any risk for the candidates. So, and then I would be very happy to have people coming to this course. And Ashraf is giving a lecture during this course as well. Thank you, Ashraf, again.
And of course, it's a very, very needed also to mention that Dr. Walid Al-Habashi and his academy, Saving Lives Academy, has 3 simulators, and he is running courses with hands-on on simulator. So go ahead, Dr. Walid, and start your presentation.
Perfect. So please advise we can see my screen.
I see, yeah.
Perfect. So because I am talking after Ashraf and I had seen a few of your questions, I had the chance to add 2 or 3 slices to answer a few of the questions. So I just clicked answer live and we'll go through them quickly. So someone asked, I think Dr. Nabil Al-Bastawisi asked about the anatomy and how to handle the probe. So I thought it's very nice to see how the probe looks like. So there is omniplane angle, which we manipulate with this thumb and index finger, so not thumb, index and middle fingers, with angle right and down. So the top button decrease the angle, just to confuse you, and the lower button is to increase the angle. These 2 knobs, one is big and one is small, or 2 wheels actually. This is the side view of the probe, and if you look from that perpendicular to this, you will find this big wheel and small wheel. So actually you don't need to memorize anything because the big wheel is represented by a big arrow, which says A, which is anterior, which is anti-flexion, P is posterior or retroflexion, and here the small wheel, which is actually on top here, the small arrow is the presentation of the small wheel, says this side is right and this side is left. And this is the camera, or we actually call it a camera. It's not a camera, it is the omniplane or the transducer. This is the transthoracic echo probe, but inside the esophagus. So here, what are the movements in that side of the probe is what you cannot really sometimes imagine. So I put a video here. So this is the anti-flexion. So this is when you move the knob towards the anterior. You see, it's like a hook. That's why never make anti-flexion and pull back the probe, because this is very traumatic. So this, what I did now is left flexion and right flexion. So this is side to side flexion, left flexion and right flexion. So the only movement remaining now from the physical movement is the retroflexion. So this is how we move the probe. So this is video is by myself. So just to explain, it will be like a hook. So never use that silver button, which is the lock button. If you lock your probe in flexion and then pull back, this is actually the commonest cause to cause esophageal injuries, and it's actually iatrogenic. So please always remember, don't use that silver locking button. Is that imaginable how to do that? So the movements of the probe are physically push in or advance your probe in, or pull out or withdraw your probe. So in and out, very simple. Or what you need to do, imagine this is my probe and it's going in the esophagus or coming out of the esophagus. Very simple. There is another movement which is anti and retroflexion with that big wheel, right and left flexion with a small wheel. Then you don't need to use this too much right and left rotation, except in just one view when you do right rotation to get the bicaval view, and left rotation or the opposite side to get the descending aorta views. And then what is left after that in the manipulation is 0 to 180 degrees of the omniplane angle. I would like you to imagine this is my right hand. Imagine this is my ultrasound scan sector going down in the esophagus. Always use your right hand with the thumb point to 0 degree, and your little finger is pointing to 180 degrees. So this is 0 and 180. So 0 is when I'm going down in the esophagus by my right hand, and then I start to change the omniplane angle. So 90 is perpendicular to the 0 and 90. Okay, so if I'm coming from that behind left atrium in the esophagus, as you can see here, this is the heart. I'm coming from the back here. This is 0. So once I reach here, this is the 4 chambers view. And then I start to change my angle by increasing the omniplane angle to be from 0 to 120 or 130. We rarely go beyond that. So these are the views. Just Dr. Nabil again asked how to memorize or how to do the TEE probe movements. Actually, there are more than 20, 25 or 24, 26, depends on the source you're reviewing from. We're not using any of that in ICU. Our ICU is much more simplified. We omitted 10 views and we left you 10 basic views just to master. And again, I'm not going through that one, but these 10 views are composed of first 3 to assess the ventricles, and then to assess the valves, then to assess the great vessels, including bicaval and aorta, and then end up by transgastric short axis view. You can use that in short axis and long axis, and then deep transgastric view. These are the main 10 views that we teach all of us, or like there is a universal agreement to use these 10 views just for a quick 5 to 10 minutes exam to assess the cause of shock. Here, let's do the shock management. Everyone here understands the mean pressure equals cardiac output multiplied by systemic vascular resistance. Shock management. So mean arterial pressure equals the stroke volume by heart rate by SVR. So this is preload, contractility, and afterload. So stroke volume I can calculate by LVOT, VTI as what you learned in the transthoracic, same. So you can here know what is SVR. Why I am saying that? Because of shock resuscitation. In every single lecture I am teaching, mean blood pressure is very meaningless. Mean arterial pressure doesn't mean anything. So these are the normal numbers, and this is a patient with a mean pressure of 65, while his cardiac output is 4.5, so normal SVR. So if the mean is 65 with a cardiac output of 8, that means SVR is 650. And this is a patient with a 65 of mean with a cardiac output of 2, and SVR is 2600. So the mean pressure here is fixed. It all depends on how much is your cardiac output and how much is your systemic vascular resistance. That's why you need to see heart, is it a hyperdynamic, hypodynamic, or a normal contractility? Then you can see if it is a stroke volume and then go in further details. Shock management, it's either fluids, vasopressors, or inotropes plus treatment of the underlying cause. And tonight I'm giving you 2 examples of treatment of the underlying cause. So the first case, this patient is elderly gentleman who arrived to us referred after a cardiology, had inserted a transvenous pacemaker, and as per this cardiologist story from peripheral hospital, that after the transvenous pacemaker worked for a few minutes, it stopped working. So I started to manipulate the transvenous pacemaker, and then the patient had his shock state. So he is presenting the scenario as if the pacemaker was on the RV, and there is an RV infarction, but it doesn't regularly happen in few minutes. It's usually 24, 48 hours, where the tip of the transvenous pacemaker may cause a myocardial infarction at the tip of the RV. And then when they manipulate in an infarction segment, it penetrates and causes some cardiac tamponade. So because we had been in that stage as a cardiac center, the patient came to us intubated, ventilated, shocked. We admitted him, and the first thing to do is a transthoracic echo. Unfortunately, that patient was not showing any proper windows. So we put a transesophageal echo probe, and the first thing we found is this image. What is the view here? Who can give me the answer? Put it in the chat box, please. What is that view? And do you see it as normal, or do you spot any abnormality? I cannot see any answers yet.
I'm checking it in the Q&A, but there is none. Yeah.
Please, can anyone tell me what is this view? What is the name of that view? I'll give you a few seconds. So if you see the left atrium here with 2 atria and 2 ventricles, it is coming from the transesophagus. So this is 13 angle, so it is almost 0 angle. So this is the mid-esophageal 4 chambers view. So 1, 2, 3, 4. So this is at 0 to 10 degrees. So is it normal or abnormal? As you may experience here, there is a big left atrium, which expected in a heart failure patient. That's why he was getting the transvenous pacemaker. And here, this is something here just below the anterior mitral leaflet. So why is that? There is a shiny structure here, which I'm expecting to see the transvenous pacemaker gone to the RV. However, I don't see anything here. I actually can spot hyperechoic echogenic shadow here in the LV, just underneath the anterior mitral leaflet. Interesting. So if you get one view and you find abnormality, we always say one view is a hypothesis, two views are a finding. Who can tell me in the chat box what is the perpendicular view to that? What you want to do in this view? So I am at 0 degrees or 0 to 10, and I found this one. So the perpendicular view will be the mid-esophageal two-chamber view, okay? So, or alternative view is the mid-esophageal long axis view, correct? So we didn't see anything in the mid-esophageal 2, but we were surprised when you put that long axis view and pulled the probe slightly backwards to see if there is anything coming from up. We found the transvenous pacemaker is coming actually to the aorta. So they insert the transvenous pacemaker from subclavian, okay, subclavian vein, and it should go the right side. So subclavian vein to the superior vena cava, to the RA, to the RV. This is where it should sit at the end. Interestingly, this patient had his pacemaker inserted by mistake via subclavian artery going to the ascending aorta through the aortic valve, through the LV, and actually it looks like it's penetrating the posterior inferior wall of the left ventricle. Okay, let's confirm that. So this is a short axis transgastric view with that pacemaker wire is penetrating his left ventricle here. And then going in one of our views from bicaval to the aorta, we experience the left lung in our way. So we had seen a left hemithorax. So the lung is collapsed, the left lung is full of blood, or left pleura is actually full of blood. And this is all the views we had got here. So mid-esophageal 4, mid-esophageal long axis, and short axis gastric view, and all of them are showing the transvenous pacemaker wire had actually gone from the aorta to the aortic valve to the LV wall. So this is the inferior wall in the deep in the gastric short axis view, and it actually penetrated to the pericardium, to the pleura, causing actually a left-sided hemothorax. And this is the wire penetrating the lungs, and this is the VATS approach. It was a massive case. That's why I'm saying shock assessment. If you can't find a proper transthoracic echo views, don't presume and don't behave like you don't have a facility. You should have, because we had been a cardiac center, so we have done it, and patient went straight to the operating theaters, where under vision we had withdrawn this. The surgeons, definitely not us, had withdrawn the wire and then looked at this penetration, and they went into a very small penetrating wound here, and they had sutured it by 2 sutures, and that was the end of this game. And patient went back to the ITU, intubated for the shock, completion of resuscitation, and then he had survived this nasty iatrogenic injury. Is there any comments, questions? Please feel free. Dr. Assam and Dr. Ashraf, please, the floor is yours if you'd like to.
Very, very interesting case, Dr. Walid. And even it's very rare to happen. And even the course of the subclavian artery should go down. And unfortunately, it went back to the height. But
we never thought this will be the case before we put the TEE probe in.
So,
Yeah, so it was a very interesting case, very
This is the
rare.
value of TE, صح? This is the value of TE.
Very rare. That's very rare. So we had actually believed the story. It's common, but it's not common in the first few minutes. So when he manipulated, we thought it's manipulation of the pacemaker had caused penetration to the RV. Because it's how come a cardiologist who is doing that like on almost weekly basis get that mistake? So it's very rare finding. Okay, this is another. So this is the transvenous pacing wire penetrating, and this is actually the pleural lung, and lung was collapsed.
Let me just because there are some questions here, some comments while you ask
Yeah, please.
candidate what was the view.
Okay.
They mention apical four. Here in transesophageal, we call them mid-esophageal four.
Yes.
So mid-esophageal four is
transthoracic minded. Yes.
Yeah. As Dr. Walid showed and Dr. Issa mentioned, that the transesophageal echo is mandated sometimes. And see this case Dr. Walid is presenting is a great example of this. Go ahead, Dr. Walid.
Thank you very much. So I believe maybe in 10 years' time, you will need as an intensivist to master both transthoracic and transesophageal. It's not either or. It's like when we say, is it echo or pico? It must be both. You need to master both because sometimes transthoracic is very helpful. It's quicker. It's in ED. It's like you can get the cardiac output in 2 minutes in ED. You can't put transesophageal echo in ED for every patient, and you wouldn't do that in 2 minutes. So it's very quick just to assess. But if you're looking at following up your patient, again, transesophageal is better, or you need a PICO or invasive hemodynamic monitoring to keep measuring and repeating your measures on the cardiac output. So it's never either or. All this will be mandatory in every ITU in like 10 years' time when everyone is trained to do the same. So second case here is a very interesting case back to 2016. So 10 years old case now. Not 10-year-old patient, it is 10 years old case. So this patient was hemodynamically stable, but he had in his baseline, and I will stop here. So I need some discussion about this case, please. Oh, sorry. Let me drag that one up. That's really annoying. Okay, so yeah, we'll go backward. So what do you see here? So I need volunteers, please. You can answer the Q&A. So what is this view? I'll have a look here now on the Q&A section. Okay, you can put in the Q&A for now. I will be monitoring that now. So I realized lately. Okay, so which view is that? Can anyone answer? Mid-esophageal two-chamber. Okay, so good trial, Anwar. But here I see LA, I see LV, I see RA, I see RV. So this is a mid-esophageal four-chamber view. Maybe you had seen the next one and you had been judging the next one. But yes, so let's stick to this view. Is it normal or you spot any abnormality here? What do you think of that? Can anyone tell me?
They wrote
Excellent, pericardial effusion. Excellent, well spotted. So I can normally see the endocardium of the heart, but rarely see the outer side or the pericardium of the heart separated from the LV walls. And as I see here, there is a circumferential pericardial effusion around the heart. And is it tamponading or not? What do you think here? I'm going back and forth. No, well done. So from this view, it is no pericardial tamponade. So this patient had a chronic pericardial effusion, which is looking like hemorrhagic. And the concern here, if they go for VATS, this is anesthesia-based procedure. They go VATS, transthoracic, and you would like to open the pericardium to make a pericardial window for this effusion to be drained. And it is a bit risky if they go with their cautery to the LV or to the RV or anywhere here and penetrate into the heart, because the patient will be dying in a few minutes. You're causing penetrating injury to the left heart or to the right heart, and both are killers. So let's go and identify the next view. So what view is that? So this is again showing the pericardial effusion, but which view is that? Can anyone answer me, please? Correct. Who's going to volunteer? It's a mid-esophageal two-chamber view. Excellent. So left atrium and mitral valve and left ventricle, and this is at 90 degrees. So what is the next view in our echo views focused on critical care is the long axis. So we'll do the long axis next to that. So here, this is the long axis. So this is the RVOT, and this is the aorta, and this is the mitral valve between LA and LV. And as you may appreciate here, there is still circumferential pericardial effusion. And then keep going, short axis view showing again circumferential pericardial effusion. So we got all this big effusion, but left ventricle is relaxing well and the contractility is not impaired. So this is the stage of the pericardiocentesis. So pericardiocentesis here had been done through VATS. So there is here, this is the surgeon goes with his cautery to make a small neck in the pericardium, and this is under vision. However, you see, I would like you to see that again. See that. Once he nicked the pericardium here, do you see the gush of blood? So with that blood, that is the point why we use the TE in this case. With that gush of blood, if it is if it is in the pericardial effusion is coming out, theoretically, the pericardial effusion rim will decrease in size and the left ventricle will increase in size. If that neck is actually in LV or RV, it will be the other way around. Blood will be coming out anyway, but you will find that the pericardial effusion thickness or diameter will be increasing and LV will be decreasing in size, and it will change from non-tamponading to tamponading. And then you have to go to immediately for either thoracotomy or sternotomy. That's why we recruited the transesophageal echo in this case. So again, here, immediately after the drainage, as you may appreciate here, the effusion is decreasing. You see the blood? You see the amount of blood under pressure. You may be easily fooled or deceived that this is coming from the LV if you don't see from here that this effusion is decreasing in size and the left ventricle is increasing in size. Do you agree? So even if you're under vision with thoracoscope, in this case, this is actually the trocar going here, so you can see that in your transesophageal echo. Now we give him the green light. This is the right place. You can dilate the pericardial window to get more fluids out. Do you see here? The left ventricle now is relaxing, filling the gap. So nice to do two comparisons between before and after. So this is before and this is after. At the end of the drainage, when he made the pericardial window wider, and this is the mid-esophageal two-chamber view to compare before and after. And mid-esophageal long axis view before and after the effusion disappeared. Mid-esophageal RV in and out. Here again, this is the amount of effusion almost disappeared here. So good case to compare pre and post. This is effusion, no effusion. So this is just to see how the effusions look like. And thank you very much. That is my cases for.
Can I have a comment, Dr. Walid?
Absolutely, with pleasure.
For this case, يعني, please, the last slide or the two slides before.
Share again,
very
yeah.
interesting case. تمام. And just I emphasize, it's not just the decision of whether to withdraw, but how can I withdraw the fluid? This fluid
Where exactly
in
you
two
want me to
chamber
stop?
view, yes, yes, here. If you are planning, يعني, the commonest to make subxiphoid in the CAS lab, this is about 90% of our cases. But in this case, in four chamber view and in long axis view, we'll find that. Don't forget, the right ventricle is anterior structure, okay, and it lies on the posterior structure, which is the left ventricle. Most of the blood here around the apex of the left ventricle. So if you are going to evacuate with subxiphoid, you can penetrate easily the right ventricle in this case. So the optimum or the best to take the apical view either with ultrasound guided or echo guided or either with VAD. It's not just to tell you whether you have to withdraw this fluid and the amount of fluid. And don't forget, less than 1 centimeter, it's mild. From 1 to 2 to 2.5 centimeter, it's moderate. More than 2 to 2.5 centimeter, it's large fluid. But tamponading is a clinical situation, not just maybe patient with moderate effusion and he's tamponading, and maybe the patient with large effusion, but he's مثلا cancer patient, chronic patient, and he's not tamponading, and he feels happy يعني, with this effusion. Not just the amount of the fluid withdraw or not, but just the axis you are going to withdraw fluid. Thank you, Dr. Walid, for this very interesting.
Thank you very much. And as you see here, this is 2016, 10 years back.
Yes.
So yeah, but it was a very interesting case. Again,
True.
one of the unique cases that I wanted to make you see something different from valves and all the structures that I presented in our talk. Any questions for me?
Great as usual, Dr. Walid. It's very, very.
Thank you very much, Ashur.
Yeah,
Thank you.
I was enjoying it very much. Yeah, I had a similar case to this in my previous hospital where we did a brachydcentesis guided by the transthoracic echo, and we saw this gush of blood coming, and everyone around was thinking that we ruptured but we were seeing the left ventricle expanding, right ventricle expanding, and the hemodynamics are improving. So it's once you do it and you save life, you feel how different you are doing. Thank you very much, Walid, again. Do we have few minutes for you, Dr. Mustafa Isam?
طيب اوكي
Can we make it only 10 minutes, maximum?
اوكي نو بروبلم. طيب can I share
That's Maghrib here.
طب how can I share settings or
Yeah,
what?
go ahead. Stop sharing, Dr. Walid.
I already stopped.
طيب share yes.
Hopefully
Okay.
the
طيب إن شاء
viewers
الله.
are enjoying.
Okay. طيب my slides
Yeah,
you can see my
sure.
slides? Okay.
Yeah.
Okay. Just I want to take this out. طيب. Okay, طيب we'll start with the first case. This is a 61 years old male patient admitted to the ICU with acute severe chest pain and ST elevation in inferior leads. تمام. This is a video for this patient. Just focus for يعني and concentrate what's going on. طيب. First question, view appears in the video. Mid-esophageal 4-chamber view, mid-esophageal 2-chamber view, mid-esophageal long axis view, or mid-esophageal aortic valve long axis view. Anyone answered? I can't see the bar. Can
I will see it for you.
Okay.
Shahata mentioned 3, Abdul Karim mentioned 4, Hani.
Okay. Excellent. طيب يعني we are debating between mid-esophageal long axis view and mid-esophageal aortic valve long axis view. What's the difference between these two views? Mid-esophageal long axis view you are increasing the depth of the screen to see the apex of the left ventricle. But if you decrease the depth to be from 5 to 6 centimeters, just to focus on the aortic valve, it's mid-esophageal aortic valve long axis view. This is the difference between the mid-esophageal long axis view and mid-esophageal aortic valve long axis view. Just decreasing the depth of your screen. Okay? طيب. The second, what's the diagnosis from this video? Mid-esophageal long axis view with type B dissection, mid-esophageal aortic valve long axis view with type A dissection, or mid-esophageal long axis view with type B dissection, or with type A dissection. خلاص, now we said that it's mid-esophageal aortic valve long axis view with type A dissection or type B dissection.
Can I answer?
Yes, yes.
It's a Stanford A.
Yes, Stanford A. This is what Dr. Walid told us. It's very easy classification. Stanford A, that means it's coming from the aortic valve. It's coming from the above the aortic valve. This is dissection. It's surgical. It's one of the or it's a true emergency in cardiac surgery. Every 1 hour delay counts 1 to 2% increase in the mortality for the patients. So you are running to the OR just to prepare your blood, just to prepare your patient and start beta blocker, control blood pressure, give patient midazolam, and take the patient to the OR to replace the aortic root with Bentel or some aortic root type. Dr. Walid is told Stanford A. This is easy classifications, and I urge you, all of you, to use it. Don't use the Becky because the Becky 1, 2, 3, and all that. Type A, that means coming from the ascending aorta, surgical management. Type B, coming from the descending aorta, that means conservative management. Okay? طيب.
Definitely with an acute AR.
AR, if without acute AR, but most probably طبعا the acute AR will be with type A. تمام؟ طيب. Where is the false lumen and the true lumen in these patients? يعني we can see Shehata asked, how can we differentiate between the artifacts and the true dissection? تمام? This is one of the questions. To differentiate between the artifacts and the true dissection, you have to see a flap, and this flap is moving with systole and diastole, and you have to appreciate some flow in this flap. Okay, تمام? And other criteria. But if you are going to see artifact, you will see some perpendicular to artifact for what? For the wall of the ascending aorta. It comes when you have مثلا an old machine, or you have a lot of calcification of the aorta, so you can see here reverberation of the wall of the aorta. So it's going to be perpendicular to the lumen, not coming from entry point and increasing inside, and there is a flow inside this flap, and this flap increasing during systole, and this flap decreasing during diastole, and so on. تمام؟ This is the differentiation between the artifacts and the flap. The other question, is it true? Where is the true lumen and where is the false lumen? تمام? The false lumen is always larger size. يعني this is against our belief, and this is a big sign just to remember the difference between the true lumen and the false lumen. This is the true lumen and this is the false lumen. The true lumen coming from true wall, so you can appreciate some aortic wall calcification in the true lumen. The true lumen expand during systole and collapse during diastole. So you have to put your ECG tracing and see which lumen is collapsing or increasing during systole and diastole. This is the differentiation between true lumens. The third, lower contrast density always present in the true false lumen, and the higher contrast in the true lumen. طيب. Doing intraoperative TE for type A dissection, which finding most reliable distinguish two lumen from the false lumen. We explained it. Smaller lumen with systolic expansion, ولا larger lumen with spontaneous contrasts, ولا lumen with delayed contrast washouts, or lumen adjacent to outer curvature of the aorta. Another differentiation between true and false lumen, it's in 90% of cases the true lumen in the lesser curvature and the false in the outer curvature. So we excluded 4. Type. What was the answer? Anybody answer this?
1.
1. Yes, excellent. Smaller lumen with systolic expansion. This is what we are calling to one of the features of the true lumen.
I have 1
طيب.
minute, Dr. Mustafa.
نعم.
1 minute.
Okay.
Because we have to close.
خلاص okay. طيب. The highlighted structure in this image. تمام. This is the highlighted structure. Dr. Walid mentioned it. LVOT, IVOT, aortic valve, or mitral valve.
The exam will be full of questions like this. What structure is?
تمام. What was the answer? Who answered it?
Okay. Number 3.
Number 3, aortic valve. This is the blue, the one with highlighted here, blue one.
Down to aortic valve. What's
Down to the aortic valve.
Yeah,
This is RVOT. It's very important to differentiate the structure. It can help you in a lot of things to evaluate the RV size and also in tamponating. يعني in tamponating, you will find this RVOT. You know that in aortic dissection, it can be with aortic regurgitation and also with pericardial effusion. You have to see the RVOT to see that if it's tamponating, it's collapsing, that means the patient is tamponating or not. تمام. طيب time is finished دكتور أشرف. خلاص okay, thank you.
Thank you very much, Dr.
Thank you.
Mustafa Isam. Thank you again, Dr. Walid Al-Habashi. And we have to thank also Professor Michel Slama. And of course, everyone who attended today, thank you very much. Last live webinar for this module, the Advanced Critical Care Ultrasound module, which is endorsed and recognized by ICM EDIC section as one of the activity of the European Diploma of Advanced Echocardiography. And just to remind all of you that we're gonna have the exit exam on September 16, and enjoy the coming 2 weeks of neurocritical care, optic nerve sheath diameter, and transcranial Doppler in critical ill patients, and week for review. Again, thank you very much for WICCM, and thank you very much for ICOM for all support they are doing, Habiba and the crew behind the scene. Thank you very much. See you in, I don't know when, but I promise that we keep in touch. We are here for you. If you need anything, any help at any time, use the chat through the WhatsApp to ask your question. Sit in front of your computer and review the weeks before you sit the exam. And do not forget to join us in the ceremony 26th of September to celebrate the graduation of different fellowships with the WICC EM. Thank you very much again, and see you then next.
Thank you.
Bye-bye.
Bye.